some of the some of my experience with the transcatheter mitral repair. And I'm going to tell you since the very beginning that I hope we can go over not that much in a way of a conflicting discussion of surgery against transcatheter mitral repair, but how important this tool can be actually in the armamentarium also of us as surgeons, and can be an important opportunity also for us, and especially for those of you who are in training to embrace also this additional opportunity for structural heart intervention. So these are my financial disclosures that are actually not related to this talk, which, as I said, will be focused on an overview of the transcatheter mitral repair, from the indications to the actual steps how to perform transcatheter mitral repair, some issues when performing transcatheter mitral repair, and also some complex scenarios that are becoming more and more common when performing these procedures, especially in large volume centers. So the obviously first important step is trying to identify who are the patients that could benefit most from a transcatheter mitral repair. And maybe this is going to be the most complex part of the discussion, since it's really difficult based on the evidence that has been produced over the past few years to draw a definitive line regarding sometimes the overlapping role of surgery versus a transcatheter approach. And as I'll try to mention over the course of this talk, it's really important that the structure that is present at every institution allows to have the full collaboration between the surgical and the interventional cardiology team, as to really identify the best solution tailored to the specific patient's characteristics, not only anatomically, but also from a general holistic analysis and assessment of the patient. And obviously, I think this introduction was important because we know that when we are discussing transcatheter mitral repair, we can discuss, for example, the recent ACC and AHA guidelines. Obviously, the indication for patients with primary or secondary mitral regurgitation. I think that from a very quick snapshot, like shown in this picture, it appears quite clear that for primary mitral regurgitation, most of the potential outcomes are actually leading to a surgical intervention in the decision-making algorithm. And the transcatheter approach is mostly reserved or indicated in patients who are showing a higher or prohibitive surgical risk. I've sometimes had the chance also to talk with some colleagues, maybe even surgeons who are not actually involved in a mitral clip program actively, who are not actively involved in a mitral clip program, being sometimes concerned about the effectiveness of a mitral clip approach in patients with primary. So when you don't have a simple functional mitral regurgitation, but in reality, the results in experience hands can be quite good. And I would say that now that I've been exposed also to the tricuspid treatment, I would say that now that transcatheter mitral repair has really been able to achieve excellent outcomes. It's not so unpredictable as maybe a few years ago, where a moderate regurgitation was considered to be more or less like a reasonable success. You can really be fairly effective in reducing to trivial, mild mitral regurgitation. So with endpoints, at least acutely, which are not different than the surgical ones that we aim in the OR, the situation is a bit different with the tricuspid valve, where I think the repair is still a bit more challenging, especially in terms of how consistent we can be in producing such results. So I think that overall this slide is fairly fair in a way of recommending the transcatheter approach in patients who are otherwise considered high risk. I think that the one about the indication for secondary mitral regurgitation has definitely raised a lot of eyebrows or concerns or criticism, especially since surgery has been almost downgraded to a 2B compared to a transcatheter approach, which is a 2A. And I think that the reality, again, I don't think we have the time tonight to have a deep dive in all the different nuances, but I think in a way, part of this is also being associated with the type of treatment that surgeons have offered when doing mitral valve repair in functional mitral regurgitation, because we have to be quite frank that most of surgeons have, for example, been doing a mitral valve repair by means of an annuloplasty until probably a few years ago, where the CTS trial actually showed how high can be the recurrence of mitral regurgitation in functional mitral regurgitation when a repair is performed. But we should remember that basically all patients receive in that group only a annuloplasty. So in a way, for sure, also the type of treatment we have offered has influenced the potential interpretation of the value of the surgical treatment, and probably a more careful view in the next few years will help revising as often the pendulum swings one way or another, not in such a kind of negative light for surgery, especially with a 2B, when on the other side, the transcatheter approach is for sure a very effective treatment, but we don't definitely have the long-term outcomes that we maybe have observed for surgical treatment for many years. And in a way, also the European guidelines have been offering similar indications in terms of when it would be better to use a surgical or a transcatheter approach. This is for primary mitral regurgitation, as you can see, in patients basically who are inoperable or high surgical risk. Again, for primary, these are not patients who should be primarily treated with a transcatheter approach, but only if surgery cannot be performed. As you may know, there is an ongoing trial called the REPAIR trial, which is actually aimed at assessing the outcomes of the surgical mitral valve repair versus a transcatheter approach in primary mitral regurgitation, not functional, in primary, in patients at intermediate risk. It's obviously something that, as always, will be highly debatable, since it always depends also what kind of outcomes are we going to look at. If we look maybe at hospitalization, if we look at maybe rehospitalization, so these are going to be potentially, in favor of a transcatheter approach over a surgical one. But if we look sometimes at the outcomes of the technical result, this could be potentially be different. So we'll look forward to see also what this trial will present in terms of the evidence for such population, patients at intermediate risk, which basically would be patients with an age at least of 75 years, or otherwise considered to be at an intermediate risk for surgery. And the European guidelines in terms of the secondary mitral regurgitation, again, are stressing the importance of a multidisciplinary approach. I think it should be stressed that also in the North American ones, the role of medical management is quite key. We know that these patients need to be medically optimized before a intervention, also transcatheter, is performed. And as we'll see also in some trials, this has appeared to be a critical role in order to appreciate the benefit also of a transcatheter approach. And that basically leads us to one of the main, obviously controversial discussions based on the two major trials which have been published in the recent years, the co-op trial versus the mitral FR trial. I'm sure most of you are quite familiar that one of the main also dispute is related to the potential bias in the design and interpretation, since the co-op trial has been sponsored by the manufacturer of the clip versus the mitral, which has been sponsored by the national French agency. But when we, and obviously the reason for this controversial discussion has been related to the results of the study, since the mitral FR study was basically not showing any advantage of the mitral treatment over the medical therapy compared to the co-op trial that was showing a quite striking difference. It should be stressed that also the most recent follow-ups of the co-op trial are continued to demonstrate the benefit of the mitral clip strategy over medical therapy alone. So it's not only 1 year, but it's the follow-up, it's progressively getting longer. And obviously that has led to a lot of analysis trying to understand what could also have been the differences in the populations that have been treated in the two trials to potentially justify also the different outcomes and the different results. And one basically of the main differences appears to be the definition of the severity of the mitral regurgitation, which was basically not as severe in the mitral FR trial compared to the co-op trial. And also the overall LV dimensions in terms of volumes, which were significantly larger in the mitral FR group compared to the co-opt. In a way, meaning that those patients had larger ventricles, poor left ventricular activity, and in a way, less degree of mitral regurgitation, thereby potentially influencing also why maybe in those patients, there was not really any benefit of adding a mitral clip procedure. There was also the potential role of the optimized medical therapy that was maybe a bit more strict in the co-op trial compared to the mitral FR group, which again, I don't want to go into a discussion of the two different trials, but I want to stress for those of you who may consider embracing also this type of strategy in the portfolio of options that they can offer to patients, it's important to have a very consistent and constant discussion also with the heart failure team for patients with functional mitral regurgitation to make sure that patients are absolutely optimized before any intervention is potentially considered. And also the controversial differences between the two trials led also to another discussion about what is called disproportionate versus proportionate mitral valve regurgitation, which again, some people are saying it's absolutely a concept that doesn't exist. Others are sustaining that it makes sense, but I think it's important for the time being to stress that the description we did in the previous slide about the different population basically can be summarized into this slide, where on the left part where you see disproportionate, you're basically seeing patients with a smaller ventricle and in relation to the obviously size of the ventricle, a more significant degree of mitral regurgitation compared to the proportionate one. So again, the patients with proportionate mitral regurgitation may seem to be less likely to respond favorably to a transcatheter approach. And exactly this kind of subset of patients were probably more frequent in the mitral FR group rather than the co-op trial. This is another slide that is kind of highlighting how the relationship with the effective regurgitant orifice, as well as the left ventricular and diastolic volume, can play an important role in obviously being in a group of non-severe mitral regurgitation, proportionate or disproportionate, and how the mitral patients were more likely falling in the proportional, very close to almost the non-severe mitral regurgitation compared to the QAP trial, which again seems to give a bit more of understanding of the benefits for the patients in the QAP group. Obviously, this discussion will not be over with a couple of papers, and will be here for probably a few more years to come. I would encourage you to read maybe different perspectives and viewpoints about one strategy and the other. I personally would say that I guess most of us tonight are surgeons on the line, and if you want to read on a surgical journal, but despite being on a surgical journal, it's actually, I think, fairly balanced, and you can see some of the authors are fairly prominent, also physicians who are interventional cardiologists and not actually surgeons. This paper was very nicely, providing an overview of all the old open debates and the still question marks that we have, trying to understand the different characteristics that may lead to potential different outcomes of the transcatheter approach versus a medical therapy. And if we want to try to summarize the most recent discussions, in a way we could say that every time you have a patient that has not so severe mitral regurgitation or has a very severely dysfunction left ventricle, mitral clip appears to be futile. If you have a patient with a dysfunction left ventricle and a severe mitral regurgitation, then you can start to have a more favorable role, but still uncertain. And for sure, the population that can benefit more are patients who have ventricles that are not overly dilated, where the left ventricular function is not less than 20%, and with a significant mitral regurgitation. So we are starting to kind of focusing on a certain subset of patients who could actually benefit from this strategy. Now, as we all know, one of the main criticisms of the transcatheter mitral valve repair has been related to the possibility of maintaining a over time such remodeling that has been provided by the intervention of the leaflets, and especially since it's a ringless strategy. And this is obviously very controversial because for those who are advocating against, this is absolutely going to fail over time. And for those who are in favor, are actually even claiming that there is a remodeling effect of the transcatheter approach over the annular geometry. And actually, because it's such an highly debated and hot topic with Adam, Surab, and my colleagues, for instance, Michael Neil and Geraldine, we did this, I think, very interesting review. And since it's such a controversial topic, and what we found basically, as we in a way we're not completely surprised, is that it is actually lacking any strong supporting evidence about how the annular geometry is changing over time after a transcatheter approach. We know from the surgical series actually of Alfieri that when the edge-to-edge, the surgical edge-to-edge was performed without any kind of annular support over time, there would have been a progressive dilatation and failure. But I encourage you that once you read those papers, you need to make a distinction between those patients who are functional versus degenerative. And in some of Alfieri series, those were as well mixed. So what we basically saw for the timing is that there are actually acute changes in the annular geometry after a successful transcatheter mitral valve repair. And the few papers that describe these potential changes were actually reporting such change maintained at around 1 year. We are lacking long-term assessment, so we don't know over time how this is going to be maintained or not. And therefore, it's something that I guess would be very important for the future studies to further assess that. And this is actually an example, as you can see here. This is one of our figures in the paper, how the actually anteroposterior diameter changed from the pre-op to the post-procedural. And even here, you can almost see a sort of indentation in the shape of the anterior leaflet after a clip has been released, meaning that actually the clip, we are used to think about the alveoli edge to edge when the surgical one, when just almost the tip of the leaflets are sutured, but when you're performing a clip procedure, you're actually going to the base of the leaflet. So you're actually having a quite important effect, at least acutely. I can guarantee you that as an implanter myself, I've seen that quite impressively acutely. Of course, we'll need time to see if this is maintained over time. And to add also more constructive material to the discussion, and actually, I believe to help potentially identifying even better predictors for success and potential indication when the transcatheter approach should be performed or not. There is this really beautiful paper that was published in 2020 on JACC cardiovascular intervention, where really the authors made a very, very thorough analysis from the preoperative clinical factors, baseline echocardiographic characteristics, procedural factors, and even serum biomarkers, and how basically all these potential elements could be actually leading to impact in a positive or negative way some of the potential outcomes that endpoints that we want to analyze, from all-cause mortality, cardiac mortality, rehospitalization, MACE, or device failure. So I would strongly encourage to see that, and it actually shows that similar to what we are doing often for surgical procedures, it is not just the possibility to technically implant a clip, but to become more cognizant about the patients who could really benefit, not just because we can potentially do an effective device implantation, but because we can actually have a very also effective result over time. But one of the key things when performing a mitral clip procedure, a transcatheter approach, is for sure the echocardiographic analysis. And for those of you who are in residency or fellowship, I strongly encourage you to actually attend maybe some of the rounds when the valves are analyzed for potential treatment, because I can guarantee you that I joined, as I said last year, St. Michael's, and I had started on a in Kingston, obviously very small volume to perform clips. And I can guarantee you that I was already focusing on mitral surgery before coming to St. Michael's, but joining the structural team on the mitral has significantly improved also my attention to the echocardiographic details when assessing a valve. And I find this is so important, how to be systematic in the analysis. I've seen still some surgeons today not, for example, requesting a TEE before a mitral valve repair. And I think that one should learn to have a thorough assessment before. Doesn't matter if it's surgery or obviously a transcatheter one. And one has to start familiarizing with the main views. For example, this one that you can see here is actually a very common combination that it's used, the X-plane. When on the X-plane, you're looking at the bicommissural view. For those of you who are not maybe so familiar, typically you have the left atrial appendage here, and you're moving from lateral to medial. So you have P1, A2, and P3. And this is very important because then when you put color, you want to see how many jets and where the jets are located in a medial-lateral position. And then on the X-plane, you can then also potentially see in a direction of central or eccentricity of the jet, so that really a thorough analysis can be performed. So it's really very important to have this kind of analysis together, obviously, with a 3D assessment. One thing that can be potentially difficult to assess on the TE can be the presence of clefts. And this obviously can be a major potential contraindication for a transcatheter mitral valve repair. Sometimes these are kind of discovered in the operating room. It's the minority of cases, but it can happen, and it's important to recognize those beforehand. And the 3D view that we have on the also TEE, it's, as you know, the same surgical view you would have from the in the OR. So I think actually mitral clip, maybe it's not perceived like that, but I think that in terms of visualization is very, very easy for mitral valve surgeons. And one of the reasons why I stress the importance of the echo analysis is that we obviously recommend as one of the commandments for us in surgery to perform a surgical inspection, right, and analysis. And I would honestly ask, this is a real complex barlow where you can see a complex bileaflet prolapse. And what is the value when the heart is flaccid to basically assess here, and how one could potentially have any strong indication about which segment to start tackling in order to repair this valve. I can tell you that I did this repair by actually focusing a lot on the echo, similar to what we do on the mitral clip. And I did an edge-to-edge, a surgical one. The patient was young, so we opted for a surgical intervention and not for a transcatheter one. And I, placed the sutures based on the assessment done with the echo, and that led to, as you can see here, once injected in a very good result. So it's important also for our surgical procedures to have this kind of assessment. One parameter that we often tend to omit asking is related to the possibility to analyze the area of the mitral valve. And the area of the mitral valve should not be assessed at the mitral annulus, but at the leaflet tips. And if the area is more than 4 square centimeters, that's an important parameter for us, knowing that it would unlikely lead to stenosis postoperatively. And now I ask also for my surgical repairs, for every case, I want to know what the area is to start, because it can give me an important piece of information in case I need to do a edge-to-edge in the OR. Well, we know obviously roughly how the mitral clip works, but I'm going to go through some of the steps in the implantation. It's actually a device made of different components. You have a guiding catheter, then you have this steerable guide handle, the delivery system. And when you're deploying the clip, you really need to start learning how to use both hands to move into anterior, posterior, use the different knobs that allow to have a different angulation of the clip. The way the clip works, as you see, you basically have the clip arms, and you can see here the gripper. So the idea is that the leaflet gets literally trapped between the clip arm and the gripper. And once it's in there, on the echo, you typically can see, we say the gripper bouncing, which means that the leaflet is basically trying to force the gripper to open. It's always a positive sign that you are able to engage the leaflet down to the very center of the clip. And then we have a series of tools from like the grippers, how to open the clip that are used to maneuver. The clip comes now in 4 different sizes. What is important is that recently we got the introduction of a so-called W, which means wider clip, which is no longer 4 millimeters, but also 6 millimeters. So it comes into these 2 options. But then we also have clips that can be shorter or longer. So overall, we now have the NT, NTW, XT, XTW. And obviously, the different features of the clip can basically needs to be tailored based on the characteristics also of the patient and the valve. So when we are selecting the clip, as you can see here, we need to think about certain criteria from the length of the leaflet, the width of the jet, and the mitral valve area. So depending if we have a leaflet left that is less than 9 millimeter or more than 9 millimeters, we can go for an NT or XT. And then depending how broad is the jet, the presence of a smaller area, the presence maybe of multiple cords in the section where we want to, in the portion of the valve, in the scallop of the valve where we want to deploy the clip. So these are all factors that we need to take into account when selecting the clip. Obviously, one of the key factors is having access to the left atrium, and this is done by making a transeptal puncture. I don't know how many of you are familiar with this transeptal puncture, but we may think as surgeons, oh, just go and, poke the septum. That's it. It is actually, it requires a bit more of precision in the sense that this slide is actually very nice to show how different structural approaches may require different punctures. And in the case of a mitral clip, you need a posterior and fairly high approach. So typically we use a bicable view, and we start coming down with the device that can be used for the transeptal puncture. We have at St. Michael's device called the VersaCross, which has radio frequency at the tip and allows to perforate also very thick tips. And once you're happy with the orientation, this is the SVC towards the IVC. You typically trying to aim for the thin part of the septum. You then also want to make sure that you are in a proper posterior position. So using the X-plane, this is the aortic valve. So this is anterior, this is posterior, and you want to see the tent fairly posterior. So fairly high and posterior. And once we are happy with the tenting, we then ask the echocardiographer to measure the height from the potential tent to the annular level, because we need height to make sure that we can introduce the device and be able to maneuver the device effectively. And roughly we want to be somewhere around 4 centimeters. It can change depending on the medial lateral or the presence of primary or functional, but let's say roughly as a rule of thumb around 4 centimeters. Sometimes some septum can be quite interesting, like this very floppy septum. So it can be quite, challenging, but with the devices that I mentioned we have nowadays, it can be very precise at the puncture, even in very, very floppy septum. Then we start introducing the guiding catheter. We want to go across the septum. So we are going from the right atrium into the left atrium. And then once we are in, we start advancing the actual clip into the guiding catheter. And we need to have a maneuver that will eventually bring the clip outside of the guiding catheter until we have the 2 markers that are aligned as shown here. And this is a step called straddling the clip. Once we have the clip close to the mitral valve, we want to make sure that we have a proper angulation of the clip that has to be basically approaching the valve in a perpendicular function, both perpendicular direction, both in the anteroposterior, so in the long axis view, as well as in the intercommissural view. And obviously we want to make sure that we are chasing the problem that this patient is presenting. And typically this is demonstrated by the fact that we technically say that we want to split the jet. So if we're able to place the clip in the middle of the jet, we are actually in a good position, because probably the clip will be able to resolve the issue. If the jet is broader, obviously you need to start tackling typically first on the medial side and then moving laterally. Something to remember in terms of the orientation, if this is the surgical view, which is like the 3D view, we need to remember that the clip has a 12-6 orientation. The more we are positioning or tackling something which is a problem which is in the A2P2 position. The more we move on the medial side, we need to counterclock the clip, and the more we move lateral, we need to go in a clockwise fashion so that we do not distort the valve. And that would be the same mistake, honestly, you could do when performing an edge-to-edge in a surgical fashion if you're not actually following this kind of concept. Once we are happy with the position and the orientation, we cross the valve, we go in the ventricle, and then we start the process, obviously, of capturing the leaflets, so coming back to the atria. And this is a bit like fishing, so you have to be sometimes patient and time with the systole, diastole. And then finally, once we have good contact, we basically release the grippers, and these are now, as you can see here, bouncing because you have trapped the leaflet between the clip arm and the gripper. And we make a thorough assessment of the valve, and once we are happy, we start closing the clip, obviously, and making sure that we have no regurgitation. Now, some final technical considerations. Every time we move along the commissural line, we have to consider that there could be a potential impact on the residual area. So the more we stay very central, A2P2, the potential less impact we have as we move a bit more medial or lateral. As we move towards the medial or lateral commissure, the risk again gets lower. But this is important, especially in patients with very thick leaflets or small mitral valve area. And again, this concept is very important and can lead should lead to a very careful consideration of which clips should be used, also based on the segment that we want to tackle and the overall area of the valve. So I just want to finish by presenting you some of the challenging cases that, for example, have been performed also here at St. Michael's as an example of high volume centers. And now we are pushing a bit the envelope, trying to treat also patients with sometimes borderline anatomical suitability with small MV areas, calcified leaflets, or MAC. This is an example of a patient that, as you can appreciate here, at the prolapse of the posterior leaflet, but had also this pretty big chunk of calcium just underneath. So it's not that straightforward, because when you're going towards the leaflet with the clip, you have to basically scoop around that and be able then to capture the leaflets. And as you can see here, that's the eccentric jet. But it is actually fairly possible. So I'll move quickly to this one, where you can see the clip now has engaged the leaflets. And once we have closed the clip, we actually have an excellent result without having had any interference with the important component of calcium in the subvalvular apparatus. A very interesting case that series of cases we started to tackle are also patients with calcification from the annulus extending also in the body of the leaflet, which obviously may represent a contraindication because those leaflets may not be very pliable and may lead to stenosis. But this is something that has been spearheaded by Neil, who is really the mastermind of the mitral clip program at St. Michael's. And we basically use a new concept called balloon lithotripsy for the mitral valve, or what Neil loves to call a clipotripsy. The idea is basically to use a shockwave catheter. Maybe some of you may have heard about the shockwave, which is a system that has been allowed mostly for vascular applications, where you basically want to rupture the plaques, soften the plaques in the vascular bed. And in this case, we basically thought about using the same concept but applied to the mitral valve leaflet, which is something that has never been done before. And this is the example of what we did. We actually use an Agilis catheter, which is basically a steerable catheter. And then we placed this balloon lithotripsy, and we move from the medial to the lateral and back. And we actually use at least 2 balloons to start, in a way, making the leaflets more pliable, and then using the clip approach. Now, the role of the surgeon should not only be in the obviously during the transcatheter application, but to be there also when it's rare, but some problems may happen. And this is an example of a case in which a clip here was implanted at the level of a 2P2, slightly, let's say, in the medial side. And as you can appreciate here, I'm holding with the forceps a laceration that occurred in the at the level of the base of the posterior leaflet. And here we had a single basically leaflet attachment of the clip. So this patient was considered to be not ideal for surgery, so we prefer to opt for a transcatheter approach in the first instance. Unfortunately, the quality of the tissue was not as we were hoping, and this obviously led at the end to go back to the surgical option. And I think it's important as surgeons that we learn also how to tackle. It is possible actually to remove a clip that has been freshly implanted. You have to put a stitch and then perform counter-intraction, and basically you are releasing the mechanism of closure. So this clip was removed, and then by a careful repair, the valve was successfully repaired. You can see here I'm highlighting, actually you will see in a second, the transeptal puncture. So basically the ASD of the transeptal puncture that is bleeding, but the valve can be repaired also after this kind of complication. And I think it's important, if you want to be part of the team and bring some value, also to be able to offer this kind of expertise. As I mentioned, I'm very lucky to be part of this wonderful program that has a fairly large volume, around 150 cases a year. We have now a growing number of combo cases. That means we do a combined mitral clip and triclip at the same time. And I would say that recently I've noticed in the last year also the number of tricuspid clip isolated is also increasing. So I don't think we have to see the two strategies necessarily as two strategies that are conflicting with each other, but more in a comprehensive vision, along with the minimal invasive techniques that are definitely extremely dear, at least to my case. And the concept of heart team is really key, being able to find partners, not only to work and select patients, but I'll always be grateful. I would say in general, the team, the structural team has been extremely supportive of my practice, but Neil basically taught me the mitral clip procedure even before I joined St. Michael's. So he has been really my proctor, and in a way my mentor, and it's really exciting to work with him anytime we have the chance. So I think overall it's an important tool to have in a comprehensive program. We should be actually be part of the discussion as surgeons as to also identify the best tailored solution for each specific patient and their needs. And also we should, I think, encourage a more presence and more active presence of surgeons in a clip program, not just to bail out, but also to be operators, because I think that for those of us who are mitral surgeons, we can bring a lot of value to the table. Thanks again for the opportunity to present.
Awesome. Thank you so much, Dr. Bisleri, for that wonderful talk on the mitral clip. You came very highly recommended. So multiple people had reached out to us saying that you should be the one that's giving this talk. So thank you so much again for being here tonight. So we will open the floor up for some questions. Does anyone have a question for Dr. Bisleri? Oh, Ricky, go ahead and ask your question.
Go ahead. Hi, Dr. Bisleri. First of all, excellent talk. Thank you so much for that. I'm a chief resident at the University of Manitoba. I'm particularly interested in that last point that you made on your slide, sort of the added value of the mitral surgeon to the heart team. I'm wondering if you can give us sort of, in your mind, what would be sort of beyond MitraClip in other words, like the pathologies that MitraClip perhaps can't address that could be addressed through some, potentially transapical accesses from a surgical standpoint, or other sort of transcatheter approaches that are further down the pipeline? Sort of where do we go from here type of thing?
Hey, Ricky. So very good question. I think honestly that my strong recommendation, and especially as you said, given your position right now and your stage in your career, is that the more chances you have to basically get your feet wet with these kind of technologies, it's actually, you know, it's a process that will help you learning also the next one. I give an example. I started mostly focusing on the mitral clip and the triclip, and now I'm progressively being involved also in the TMVR or the TTVR. And, you know, when looking at, for example, at the imaging for a tricuspid valve replacement, transcatheter, I feel fairly, you know, confident because I basically spent so many hours together with Neil and Akshay on the tricuspid clip that I'm starting to master, you know, all the different echo views and what should be done also for the transcatheter tricuspid replacement. It's also true that if you're asking me about those technologies, the mitral clip is very different in the sense that it's not providing you any technical you know, skill set compared to, for example, like a TAVI. I think that you need a blend of both. If you want to do TMVR and TTVR, you need to be having been exposed to TAVIs, but at the same time, you need to have an understanding of the mitral valve. And the clip actually, in a way, if you are a patient operator, it's an excellent approach because I don't know if you had the chance to assist or be present in some of these procedures. They may be straightforward, but they may require time, but it's not a procedure that is just like a boom, go open the delivery and pace, and that's it. It's a procedure where you make sure you're in the right angle, you make sure you're right orientation, you grasp, you close, you make 5 minutes of assessment, making sure that the leaflets do not come off the clip. So it's really a very thorough analysis. And if you actually take advantage of that, you're learning a lot. Now, that's the part that I think as surgeons, otherwise we're missing, and it's an extremely positive learning experience. You, I think, need to have, for these procedures, a background in mitral surgery, for example, and being fairly expert so that you can provide value, for example, in understanding if you have a patient with not only an myxomatous valve, but you can clearly see thickened leaflets that you would figure it out in the OR being very non-pliable. If you're clipping those leaflets, you're likely going to lead to high gradients. And there have been a few cases where we were kind of, you know, debating whether it was good or not to go ahead. And I think I actually a little, you know, steered my colleagues towards maybe a non-implant rather than going for an implant, because obviously of the feedback that you were bringing in the decision, or sometimes deciding to stop the procedure and still opting for a surgical one before any implant was actually performed. So I think it's really important that you master in this case, the mitral valve quite well as a surgeon, because that can help. You mentioned about the transapical approach. I have to be honest, I had this actually conversation also with some other staff colleagues. The transapical, for example, cords. I'm a mitral surgeon that uses basically 95% cords and 5% resection. So I'm very much in favor of cords, just to tell you my surgical bias. But I can tell you that you can treat primary MR very well with a clip. And I honestly would see a very limited application of the transapical cords in the current subset of patients. So in this program, that is such a large program, I honestly see a limited value, considering that it's still a ringless therapy. I would be very intrigued, and we are trying to select the right patients to do a transseptal cords, so a complete transcatheter approach. Because one thing that I never really my personal bias, I never really fancy too much, is the fact that transapical cords are going to the apex rather than the papillary muscle. And we know about that over time, as you have a remodeling of the ventricle, that actually leads to a extra long cord, which I don't think is actually the case with the anchoring on the papillary muscle, because the ratio may not be different like the one from the ventricular side. So I know as surgeons, we are trying to do something as an alternative to the clip by doing the transapical cords. And I'm not discouraging, but I can tell you that the company is already working on a transcatheter approach, which probably, like TAVI, will become the mainstream. I don't know if that answers.
No, you very astutely read between the lines there. So I'm very, very thankful for your insights. And again, fantastic talk. Thank you so much.
Are there any other questions for Dr. Bisleri? Yes, Ali, go ahead.
Hi, Ali Hassan, Queen's medical student. Dr. Bisleri, quick question. You've talked about the MITRA FR in the COAP trials and the different echo parameters like the left ventricular diameter. Do you currently use any hard cutoffs for choosing your MITRA clip patients like that?
Good question. I think that right now, what I can tell you, so the short answer is that we obviously pay attention to the overall, patient's characteristics also from the echocardiographic standpoint. It is not necessarily a hard no-go if the ventricle is dilated, but we want to see at least a severe mitral regurgitation. And so that may lead, if we believe in the concept that still you have proportionate mitral regurgitation, disproportionate and not proportionate mitral regurgitation. I have to say that sometimes the main concern I hear also from again staff colleagues is the fact that patients may be steered towards the transcatheter over the surgical one, but I can definitely confirm you that what I've seen, at least in my practice here, is that patients are really patients where I would not actually operate on surgically, and I'm fairly aggressive. And just to share it with you, we are part of the repair trial, the one I mentioned about intermediate risk patients, and I actually had one of my patients that I enrolled in the trial, and I was hoping the patient was going for a clip, and the patient came back for the surgical arm. And just telling you that now that I'm having access to both, I'm actually for those borderline patients looking sometimes on the transcatheter approach, but we do not necessarily have a hard exclusion based on the volume of patients, left ventricle volume.
Perfect. Thanks so much. And thanks for the excellent presentation.
Thank you, Ali.
I guess I can ask the question if that's okay. In terms of training for these transcatheter skills, especially with MitraClip, I think TAVI is becoming more and more common for cardiac surgery residents and fellows to go on and do some extra training and really dedicate to structural heart. But even in dedicated structural heart fellowships, MitraClip is still not a part of it. It just really just means a TAVI and an aortic valve fellowship, really. Are there centers in North America or Europe that you know of that are kind of, bringing to the forefront this concept of also training cardiac surgery residents in transcatheter skills overall, tricuspid, mitral, TAVIs, and really kind of give them a full gamut of training?
I mean, that's an excellent question. I can tell you that I had I had a call from a fellow who had been actually working at a very famous center in the US who's part of the co-op trial or so. And then when you look at the volumes, like you're like, oh my God, I don't know how you can get any experience in clips, as you just mentioned. So it is actually a big problem. One of my, I'm going to be very honest, one of my, hope is that events like this one can in a way help, sparkling some interest in your generation, guys, trying to be a bit more involved. And I mean, I don't know, maybe I've been just fortunate, but when I was in Kingston, I started the program together with a staff colleague, and it was like very open. One time at the beginning, we were both learning. One time he was doing the transeptal, I was doing the clip. The next time I was doing the transeptal, he was doing the clip. And then I basically was fortunate to be here with Neil, that, and actually I have a guy that are extremely experienced and, progressively started to do everything. So you definitely need to look for large volume centers. And I hope that progressively there will be surgeons who are going to be staff surgeons already involved, because I'm hopeful that, for example, my involvement can actually make normal, like we have a TAVI, very active TAVI program where it's normal that you have the staff cardiologist, staff surgeon, and then the fellow, one from cardiology and one from surgery, and we all do something. And for mitral clips, I'm by myself. So I'm hopeful that progressively over time, this will change, not only here, but in general, so that you guys can start being exposed to that. Again, the beauty to me of the mitral clip is that it's not a rush procedure like it could be a TAVI. So you really have a lot of time, and it takes a lot of, I think, dedication to learn, because it's a lot of finesse compared to a TAVI. So I honestly think that it would require probably maybe just, I don't know, a dedicated year just to start having some flavor on a large volume.
Right. Sorry. Yeah, that's a very good point. I think maybe what you're getting at is very similar to kind of being a mitral valve surgeon, where you have a dedicated, fellowship for mitral valve. Just like that, you need a dedicated fellowship for kind of mitral procedure for transcatheter in your group. It's not really easy to combine those things.
I mean, I think that, this is such an evolving field for us, but I'm going to be completely honest that, like in my personal practice, I've gone from doing, also aortic surgery, frozen elephant trunk and stuff like that, and progressively focusing on mitrals. And my practice now is mostly like mitral, tricuspid. I obviously do other things, but mostly that surgical and transcatheter. Still, as I mentioned before, I learned because I thought, okay, I now kind of start to handle the mitral clip and the track clip. I could do potentially TMVR or TTVR, and it's like, oh no, that's a different thing, because you need to have a background of TAVI as well that can help as a sort of first tier level to be able to also do that. But if you ask me, probably in an ideal future, I would see myself saying I would stay between the mitral and tricuspid surgical or transcatheter, which is, trust me, fairly big, because you got so many scenarios that I think that overall we probably will be heading towards becoming a bit of specialists of certain areas. Like you are an aortic and TAVI, and then mitral, tricuspid, and that, rather than being a mix of both. And that was what I probably would recommend. So if some of you is saying, I'm interested in mitral surgery, minimal invasive, great, but do not stop there. Get your feet wet also, like in a mitral clip. Also because I don't know maybe all of the names online, if some of them are maybe cardiologists, but like it's, one of the concerns of surgeons is obviously, how can I get a referral? And when you're sitting at the table together with the colleagues, it comes natural, right? So when I'm discussing patients at the mitral rounds, if a patient is surgical, they just turn to me and I'm like, okay, you agree, like go for surgery, here you go. So you're basically having access both ways to a surgical or a transcatheter. So it's also a good way to have a say from that standpoint.
Awesome. Thank you so much, Dr. Bisleri, for all of your insights. And again, the excellent talk. I do think actually, so this concludes our mitral. I don't see any other butting hands or anything like that. And we're past the hour here, so I think we'll let people go for the night. But this concludes our mitral theme, which is awesome. We had 3 wonderful talks. Like I said, the YouTube link is in the chat box if you guys want to refer back to those at a different point. And we're going to move now into sort of the heart failure theme. So we're going to have some great talks. Actually, I think Dr. Verma is on the line right now, and he is giving us a lecture on March 10th, looking at sort of heart failure, the guidelines, really getting into some of the medical management aspect of it to start off the heart failure theme. And then of course, yeah, he just said, looking forward to it. So we can't wait to have him. And then we're going to get into some of the, mechanical circulatory support and transplant. So definitely looking forward to those. So with that, thank you so much again, Dr. Bisleri, for being with us tonight and providing all of your insights. And I think we will call it an evening.
Thank you so much.
Dr. Bisleri, and thank you, Dr. Verma. Looking forward to it.
Okay.
Bye. Thank you.
Bye, everyone.